Hello, everybody. Thank you for being here. I want to start with frustration. Frustration as a family doctor who wants to make a difference in people's health. And when I left residency, I could assign a name to problems and tell people what to do about them, but it wasn't leading to better health, and that's profoundly frustrating. I know we talk about what's missed for the patient. There's also a cost to people who go into healthcare to make a difference in people's lives and start to think that maybe the tools they're using and the way they're operating don't really lead to better health. And it isn't my own kind of renegade position on the matter. It's obvious that much more goes into health than the healthcare that people receive. And I want to focus today on this bottom chunk, this behavior patterns. In my 15-minute visit in an urgent care type setting, I can tell people you're fat, you're smoking, stop. And that doesn't lead to better health. However, there are very clear, effective ways of engaging with people to address these behaviors. And so I needed to find a way of delivering what we know works and what we know is really going to make a difference for people's health, but that I personally don't have the resources or capability of delivering. And I've been working with volunteers on coaching. And this grant really has enabled us to take this program to a level where I can offer it to you. So I wanted to develop something where it wasn't just with my intense effort, I could reproduce it at one place for one population. I knew how to train people in coaching, but I wanted to be able to create resources that made it scalable. And the model that I'm going to present to you is a way of adopting something at very low cost with preliminary results that are promising. And I would call them the secret sauce. This is AmeriCorps. And there's a 75% match from states if you adopt a program for AmeriCorps. These are full-time service members, usually college graduates, who are idealistic, amazingly optimistic about the future of our communities and dedicate a year to service. They get a stipend of $12,500, and that is completely purchased by the state. So what you're essentially doing when you bring on AmeriCorps is you're paying to coordinate them, and you're paying for their health care if they are under 26 and not covered by parents. So here you've heard a lot of ways of addressing social determinants of health, behavioral determinants of health. This I propose is a workforce that can be highly adapted and effective and attractive to a system that needs a low-cost source of boots on the ground. The second component was creating a model of training these individuals that could be easily replicated elsewhere. So I'm a certified trainer motivational interviewer, which is the core skill that we teach the coaches, but that's not good enough for anybody else. I'm not going to be able to go to every site that I'm proposing this for. So I wanted something to be free, online, and standardized. So I turned to course sites, and these volunteers, they get an initial training in motivational interviewing. They also get trained in a way of assessing the quality of a conversation that's recorded that measures the fidelity of that conversation to motivational interviewing. And then they also take the IHI Open School Quality Improvement course. So we focused on tobacco cessation. The long and the short of it is, what do you like about your smoking? What do you not like about your smoking? And then you give a summary that weights the importance they give about not liking their smoking. How important is it to you to quit? How confident are you could be successful? And you're just asking that. That's the basic rubric. The really cool thing is that after this online training, they've learned how to teach each other motivational interviewing. So I'm not going to be there the next time they teach each other motivational interviewing. They're going to put a recording, they're going to play it in a room, they're going to use poll everywhere, and they're going to evaluate themselves. They're going to vote online using this free tool. How faithful is each utterance to motivational interviewing? And they're going to teach each other essentially and improve their practice. This is a validated measure to train to fidelity in motivational interviewing. A 5 on a scale of 1 to 10 is considered basic competency. So that's putting somebody in a clinical trial and saying they're good enough to deliver MI. So this group didn't start at a 5, but they got there, and they've been there since then. So you have a validated measure of training lay people without prior experience in motivational interviewing in a community that essentially teaches itself. It doesn't require Nick Cohen to come to your institution. You do this online, use this online resource, and then you've got a group of people who know how to teach each other how to improve practice. So does it work? Essentially what we did is we paired these coaches trained in motivational interviewing for tobacco cessation in primary care clinics and hospital sites. And then they had a brief conversation after a referral from a clinician or the admitting nurse. And then we called them at 30 days follow-up. So this has been going on for about 5 months. The parentheses are what I would have to publish in the literature if I was, because that's the honest results. So that's the intention to treat. Because we had 152 patients, but only 44.7% were reached. So the number I'm bragging about is of who we reached, but the honest number is the whole population. You have to assume that everybody who didn't reach didn't change. So the honest numbers are that 11% quit. If I only look at who I reached, it's 24%. That's consistent with the best studies of motivational interviewing. Half of them reduced, 22% with intention to treat, and 25% or 11% intention to treat had no change at all. So if we can get better at following up with patients, we might have an improved quit rate. But going between 11 and 24% at 30 days is going to be exciting. Now, the next thing I wanted to do, so I gave you the broad numbers, is to focus on what happened to me. So here I am in clinic. These are the patients I've seen over the past 5 months. Before I had a coach in October, I was not providing brief advice to anybody who was a smoker. As the coach, I became familiar with them and started to trust that this would work. I started to refer more. And so this is the referral rate, and this is me, but this is what we were seeing across the board. That providers are willing to give that brief of advice if they know it can be followed up with an intervention that works. And so the next question was, does it change anything else about the way I practice? So I wasn't giving advice. Now I do it in 70% of the visits because I know it can be backed up by something that works. Well, I also wasn't prescribing nicotine replacement for smokers in October. And as I learned that the coach was going to assess their interest in the products and I could put in a standing order in our clinic to make so that the nurse put in the order, that it was not this big thing on my practice to actually start prescribing nicotine replacement. So this you can see from no prescribing to about 1 in 5 patients are getting this nicotine replacement product. And the last thing I wanted to know is there an economic case for this? So essentially, what I've realized in this clinic is that when I'm billing a level 3, well, I'm getting $13 for providing 5 to 10 minutes of counseling, 3 to 10 minutes of counseling. And what I'm realizing is that when I have a low to moderate complexity visit, an O3 or a 1-3, and I add on tobacco cessation, I'm increasing the complexity of my billing one step. So I'm going from an 03 to an 04, or a 13 to a 14. So I looked at the number of patients who I provided brief advice for, because I was consistently billing at a higher level when I was able to do that. So you can see as I increase the rates of counseling, the level of complexity of my visits increased, and up to about $1,000 for someone who's a 0.3 FTE. So the program actually that makes a cost savings for the institution. So that's it. I just wanted to say that I tried to make something that would work for you, and I think it would. Thank you.